Welcome back to Vet NeuroJar. Today, we're diving even deeper into the world of veterinary neurology, specifically focusing on the lower motor neuron, LMN, system, and the diseases that can compromise it. Get ready for an in-depth exploration of anatomy, diagnostics, and real-world cases. So, what exactly are we talking about when we say lower motor neuron?
Simply put, it's the final common pathway through which the central nervous system communicates with muscles. Think of it as the last relay station on the line from the brain to the muscle, responsible for executing movement. The journey begins with the neuronal cell bodies of the general somatic efferent, GSE, motor neurons, nestled within the ventral gray horn of the spinal cord. These cell bodies aren't scattered randomly. They're organized into columns based on the muscles they innervate. Those controlling proximal limb muscles reside in the ventral portion of the lateral part of the ventral gray horn, while those for distal limb muscles are in the dorsal portion. Each spinal cord segment has dorsal and ventral rootlets that attach to the dorsolateral and ventrolateral aspects of each side of the spinal cord, respectively. The spinal ganglion is located in the dorsal root before it merges with the ventral root at the intervertebral foramen. Now, picture this. The axon of a GSE neuron exits the spinal cord as part of a ventral rootlet. These rootlets converge to form a ventral root, which then joins with a dorsal root to create a spinal nerve. The axon travels as part of a specific named nerve to reach a specific group of striated skeletal muscles. The source notes that the part of the axon within the spinal cord is myelinated by oligodendroglial cells, whereas Schwann cells myelinate the part of the axon located within the PNS. This distinction is key because certain diseases target one type of myelinating cell over the other. A nerve consists of a collection of axons in the PNS myelinated by Schwann cells encased in connective tissue. At the muscle, each axon branches, with each branch ending at a motor end plate on a muscle cell. Interestingly, while fetal muscle cells may be innervated by multiple neurons, each adult muscle cell receives input from only one motor neuron. The number of muscle cells innervated by a single GSE neuron is known as the motor unit. This number varies, with proximal limb muscles having units of 100 to 150 muscle cells, while extraocular muscles might have only 3 to 4. The strength of a muscle contraction depends on the number of motor units activated. At the motor end plate, the axon terminates in small branches on the muscle cell membrane, forming a neuromuscular junction or synapse. This junction consists of an axonal terminal covered by a Schwann cell, with the axon extending into a sarcoplasmic trough on the muscle cell surface. The axon terminal is filled with mitochondria and synaptic vesicles containing the neurotransmitter acetylcholine. The space between the nerve and muscle, the synaptic cleft, is where acetylcholine diffuses to bind with receptors on the muscle cell membrane, initiating muscle contraction. So, what happens when things go wrong with the LMN? How do we recognize LMN disease?
The hallmark is paresis or paralysis. Paresis is defined as weakness or deficiency in the generation of gait or the ability to support weight. Paralysis should only be used to describe the complete absence of voluntary movement. Unlike upper motor neuron, UMN, disease, LMN paresis is characterized by a lack of ability to support weight. Muscle atrophy is another telltale sign. Without proper nerve stimulation, muscles begin to waste away, sometimes rapidly. Hypertonia, or decreased muscle tone, is typical. Affected limbs feel flaccid and floppy. Areflexia, or hyporeflexia. The source mentions the patellar tendon reflex as an example. Fasciculations, which are involuntary muscle twitches, may be observed. Interestingly, nociception is often preserved, meaning the animal can still feel pain. The source uses a case involving a dog, named Coleman, to illustrate these points. Muscle and nerve biopsies provide valuable information about the structure and health of these tissues. Advanced imaging, such as MRI and CT scans, can visualize the spinal cord, nerve roots, and surrounding structures. Now, let's delve into some specific LMN diseases that you're likely to encounter in practice. Polyradiculoneuritis, PRN, also known as coonhound paralysis, is an immune-mediated disorder targeting the nerve roots. The term radix in the name refers to the inflammation of the ventral roots. While a history of raccoon exposure is often cited, it's not always present. Paresis often begins in the pelvic limbs and progresses rapidly to tetraplegia. A change in voice can be an early indicator. Botulism stems from exposure to the botulinum toxin, which blocks acetylcholine release at the neuromuscular junction. Sources of the toxin include ingestion of contaminated food, carrion, or absorption from an infected wound. Myasthenia gravis involves a breakdown in communication at the neuromuscular junction. In most cases, the body produces antibodies that attack acetylcholine receptors, preventing them from binding acetylcholine. This results in episodic weakness that worsens with exercise and improves with rest. Clinical signs can fluctuate, and the animal may appear normal after rest. The focal form can cause megaesophagus, regurgitation, and weakness in the facial, laryngeal, and pharyngeal muscles. Tick paralysis is caused by neurotoxins secreted in tick saliva, leading to a rapidly progressive paralysis. A travel history is important when considering this diagnosis. Polymyositis is an uncommon inflammatory muscle disease. In addition to diagnostic testing, a thorough and careful neurologic exam can help localize the problem. Spinal reflexes. The source stresses the importance of evaluating reflexes like the patellar tendon reflex, femoral nerve, and withdrawal reflex, sciatic nerve. Postural reactions. Assessing hopping responses and other postural reactions provides insight into the overall integrity of the nervous system. Cutaneous truncate reflex. This reflex can help identify the level of a transverse spinal cord lesion. A mild compression of the skin alongside the spinous processes of the vertebrae should produce a brief contraction of the cutaneous truncate muscle, causing the skin of the trunk to twitch bilaterally. Signalment. Breed and age predispositions can narrow the differential diagnosis. Diagnosing LMN diseases requires a blend of keen observation, meticulous examination, and strategic use of diagnostic tools. By understanding the anatomy, recognizing the clinical signs, and considering the common disease processes, you'll be well equipped to tackle these challenging cases. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.